air or something. It's a nice day out there from what I can see. So this afternoon, as I said earlier, we've got sessions with Dr. Ben Henry and with Lorraine Curry, who's a national MCA lead, and I know that you're really going to love listening to Lorraine. But first of all, we're going to play you a little film that I made, or a little interview that I did with James and Heidi. So James and Heidi, who opened conference for us, I interviewed with them. So forgive me, and I fumbled more than they did. They did absolutely brilliantly. And I kind of think there won't be a dry eye in the house, and I will struggle following this. I've seen it many times, but I will struggle to compose myself straight afterwards. So with that, I will pass you over to the lovely James and Heidi. Hello everyone. I want to introduce today this lovely couple in front of me. This is James and Heidi. I'd like you to, James and Heidi are here to talk to us today about happiness. And I've known James since he was very, very young. And I've met Heidi a couple of years ago, so I've had the pleasure of knowing you both for a little while. And I'm going to ask you if you could tell everybody who's listening what happened last year to make you both happy.
Last year, what made me happy seeing Heidi, we were, when we were stuck in lockdown, we had a reunion.
And we got married in July.
You got married in July?
Yeah.
So tell me about your wedding.
Oh, wow, it was lovely. It was a bit of a small wedding because of lockdown, but it was lovely, wasn't it?
Yeah.
And my dad and his friend, his brother called the anchor, so they let us use that.
Oh, that's good. So you were going to have quite a big wedding, weren't you?
Yeah, we were, and then we had to cut down from
200 guests to 30.
Wow.
So it was a big cut.
Are you still going to have a celebration with a lot of people at some point in the future?
Well, we're not sure yet, but hopefully we can have it this year sometime due to COVID. But we're going to probably extend the date. It'll still go on, but a later date.
But you couldn't wait to get married, so you went ahead and got married.
Yeah.
Okay. And how is married life?
We love it. So in married life, we're enjoying it. We've been having, I've been doing filmmaking, and we've been watching films and telly, haven't we?
Yeah, and I'm loving it.
You're in love with married life?
Yeah.
Yeah, I love it. I love having a new, I like having a new person to live with. Because it's very easily.
Did you have to do any preparations to get married?
Yeah, we had marriage prep with Heidi's pastor from church called Paul Watts.
And that actually meant a lot to me because he was the third person to hold me when I was born.
I remember from watching the recording of your wedding that he said he held you when you were a tiny baby.
Yeah, so that meant a lot to me that he married us.
And how is married life?
Oh, we're loving it. We do a lot of cooking. We're making toad in the hole today.
Oh, your toad in the holes are legendary, aren't they, Heidi?
Thank you. I think it's because we put baking powder in.
So Heidi, you used to live on your own before James moved in with you. Have you had to make any compromises together?
Oh, I've had to adapt to sorry, it's hard.
That's okay. It is a change, isn't it? Living with someone when you've been used to living on your own.
Yeah, we've had to change our bed from a single one to a double one.
Well, that sounds like a good plan. And you both do the cooking?
Yeah, we do the cooking with the staff. We have 2 workers.
We sometimes split the jobs.
That's good. So you help it support each other.
Yeah.
Yeah, he's very good at. I used to do the washing up someday, but then he got bored of doing it all over again. So now he does it all.
Oh, that sounds like a good plan. I'd like to marry somebody that did all the washing up for me. So our conference today is about happiness. So can I just ask you both, what makes you happy?
What makes me happy is having film nights with my wife.
Well, I would say a lot of things make me happy, but my short answer is my husband makes me happy.
That's brilliant. James and Heidi, thank you so much for talking to us today. It's been really nice hearing about your journey to get married.
It's okay.
Thank you.
So I told you it was a bit of a tearjerker. James and Heidi are such a happy couple. I was hoping to go to their wedding. I had an invite, but I got to watch it on YouTube along with all the other guests. So I really hope they do have their big day with all of their guests at some point. So I'm all choked up now, can't talk. My team told me I could cry if I wanted. So I'm going to hand you now over to Sandy, our lovely Sandy in the team, who is going to talk about the Mental Capacity Act and the key to happiness.
Hello everybody, I'm also one of the advisors in the Mental Capacity Act team and I hope you're enjoying the day. Following on from Rachel's story earlier, my story is also about what's important to the person. My first slide, what's the key to happiness? We all have a fundamental legal and ethical right to determine what happens to us, including our ability to be able to express ourselves freely, to make choices and decisions and to take risks. This is essential for the maintenance of our independence, our health and well-being, our quality of life and ultimately our happiness. The Mental Capacity Act is essentially about people and their rights rather than just a process, and for the majority of people, the risk of losing their right to their independence and choice and control over their lives is a far greater concern to them and far outweighs many of other potential perceived or apparent dangers in their lives. Enabling a vulnerable person to take risks might often feel at odds with our concerns about keeping them safe, and there's often this dilemma between maximising a person's autonomy and freedom versus their need for care and supervision. It's therefore often complex to identify what's an acceptable level of risk to them if we intervene without a clear legal base, where we could be accused of undue influence. Equally, we also worry that if we don't intervene to protect a person who might be at clinical risk, as practitioners, we could be seen to be neglecting our duty of care. This is where our legal literacy becomes key, as we can make reference to relevant current case law to support our decision-making process. I just want to share with you briefly the story of Mr. X. Mr. X is an 83-year-old gentleman living alone in a one-bedroom ground floor flat in an extra care housing development. Some years ago, Mr. X suffered a right-sided weakness as a result of a left-sided stroke. And following his stroke, he didn't engage particularly well in his rehabilitation. His speech was also severely affected following the stroke, and he struggled to express his wishes verbally. As a result, he'd quite often become frustrated and agitated. Mr. X is also diabetic, and he's got a history of recurrent leg ulceration, pressure ulcers, and other medical comorbidities. Mr X has been supported with a package of care 4 times a day, provided by 2 carers, and over time he's been resident in his extra care facility. He's also received a significant amount of input from his GP and from the rest of the multidisciplinary team. Mr X has got a history of varying levels of concordance with his care, but with familiar staff, encouragement, reassurance, negotiation, and the right approach, he will sometimes respond to support. However, alternately, he'll regularly also decline care, the use of recommended equipment, and decline to engage with care staff, and sometimes he can appear to be quite aggressive towards them. Mr X's GP was concerned that his condition was deteriorating, his needs had increased, and it was becoming progressively difficult to meet his needs. The district nurses were also struggling to meet his needs and his wound management due to his lack of concordance. So his GP called an MDT meeting to discuss the ongoing clinical risk to him. And she felt that his recurrent wounds and pressure ulcers could lead to complications, including infection, potential sepsis, and possibly amputation in the long term. His GP requesting in the end that she felt he probably needed a nursing home placement. And she was asking that be sourced for him because she believed that he lacked capacity to make decisions in respect of his residence and care, as he lacked insight into the potential risks to himself. However, despite his significant communication difficulties, Mr X was subsequently assessed as clearly able to understand, retain, acknowledge, and weigh up the potential risks to himself, and to communicate his wishes to remain resident in his flat. And he consistently objected to the prospect of a move into residential care. Mr X has always expressed his wishes to be as independent as possible, which was important to him, and during his lifetime he'd always been described as a man who liked to be in charge. His fluctuating concordance with professional advice appears to have been an ongoing issue for some years. Mr X had experienced significant loss in his life, and therefore he may have perceived this as his only opportunity to be able to express his choices and wishes, maintain some autonomy and control over his life and his environment, and make independent decisions related to his care, even if they were thought by professionals to be unwise. The fact Mr X may be making what professional practitioners perceive to be risky or unwise decisions by not following professional advice is not in itself an indication that he lacks capacity to make those decisions. Baker J reminds us that the question of capacity needs to be approached in a detached and objective way, where there's a natural desire to be protective of an adult. So I believe that actually, even if Mr X was in a residential or nursing placement, it's unlikely that his level of concordance and meeting his care needs would be any different, or that his choices or decision making would be any different. So whilst it is important to safeguard a person's safety, it's more important to consider their happiness, their quality of life, and what's important to them as an individual. And as Lord Justice Mumby reminds us, what good is it making someone safer if it merely makes them miserable? Decisions made in the real world often require a degree of compromise, but we still need to think about people's previous lived experiences and the wishes of the person. Equally, when identifying challenges, it's about carefully weighing up the pros and cons to balance the perceived risk to the person, but with a genuine desire to maintain their autonomy and enable and empower them rather than undermine their potential. This process involves us taking a thoughtful, inclusive and enabling approach to their well-being and consider the human impact of our decision making and ultimately the happiness of that person. As far as I'm aware, Mr X is still resident in his flat in accordance with his clearly expressed wishes and with an increased package of care. And that, I believe, is my positive story for today. So thanks very much for listening.
Thank you, Sandy. That was brilliant. You always go into such a lot of detail, and that's really, really helpful. And I know we get quite excited as a team when we hear of somebody going home. I know it's not always possible, but that balancing of risk and unwise decision making and autonomy is such an important part of what we do. So we're now going to talk to Ben Henry. Dr. Ben Henry is a psychiatrist working with adults. Ben's passionate about the Mental Capacity Act, and he's been doing some assessments for us while we've been having to work on a remote way. Although Ben lives and works in London, so we probably lose him as soon as we can go back to face-to-face assessments. I believe Ben's been advising the House of Lords on liberty protection safeguards, although I might have that wrong. If I have, Ben will correct me later. So Ben is going to join us via Teams. We've got a film that Ben's made as everyone else, but Ben is with us live and we'll be looking at your questions as you pose them. So Ben can actually decide which questions he wants to answer on the chat or which ones he'd like to talk about afterwards. And the other thing that you need to know about Ben, which Judge Simmons would like, is that Ben's got a really cute little dog called, I've forgotten his name, Brian, that's right. So I will hand you over to the film of Ben and then we will get Ben to have a chat with you.
Hello, my name is Dr. Ben Henry. Let me start by giving you an overview of today's presentation. I'm going to speak with you about how to carry out a great quality assessment of somebody's capacity to make a specific decision. I'll then move on to discussing with you how to write a report that stands up to scrutiny and some of the key things to remember when doing so. We'll then discuss some of the potential obstacles that we, as assessors of people's capacity, can experience when undertaking assessments. Following this, I'd like to talk about some of the lessons learned over the course of the pandemic working in this field. And finally, I'll move to speak briefly about life, liberty, and the pursuit of happiness, the core of today's meeting. Firstly, let me start with a little bit about me. I've been a psychiatrist for 19 years. I sometimes wonder whether my age shows it. I'm not sure. Hopefully I look a little younger than that. I have clinical experience working in a variety of different areas. I've worked with older adults, working in research memory clinics, psychiatric inpatient units, and general hospitals in liaison psychiatric settings. I've also worked with people under the age of 65 too, and again, in a number of different clinical settings. For the past 7 years, I've worked independently, and most of the work that I've undertaken has been on behalf of NHS Foundation trusts and local authorities. And the majority of my work has been assessing people's capacity to make particular decisions. I've carried out hundreds of assessments and written the same number of reports. So let's start out with some of the principles which will help us to undertake a great quality assessment of capacity. Simple things are worth repeating. Developing a rapport is so important, and trying to do this can really pay dividends when assessing a person's capacity to make a specific decision. What do I mean by this? I mean that if we knock on somebody's door and sit down with them, introduce ourselves with our professional title, and tell them that we're going to assess their capacity, we will of course then go on to explain the decision which we're going to assess in relation to their capacity. It probably won't mean a great deal to them. We should start by trying to develop a level of engagement. I find that the following phrase, "tell me a little bit about yourself," can be really helpful in doing this, because people like talking about themselves. People like telling you a little bit about their lives, what they enjoy. If you struggle with this, it might be worth getting in contact with the person you're assessing's family to find out what their previous interests were, because then you have something you can speak with them about and which may allow you to build a rapport. I've mentioned a case on the slide, and I'm going to quote now from that case. "However, With patience and good humour, Dr. Miners-Wallace managed to establish a rapport. Persistence paid off, as his account of their discussion about sex reveals. In the case in question, Dr. Miners-Wallace was the capacity assessor, and he'd been asked to assess a lady's capacity to make a number of specific decisions, including those around sexual relationships. Dr. Miners-Wallace comments that most people would find this impertinent and intrusive, and of course any of us here today would, most likely. But he developed a rapport with the person he was assessing, and she allowed herself to be assessed. She didn't want to engage in the assessment, and as the judgment shows, she said, "Just get on and ask me the questions you want to know the answer to." Something that's documented as occurring in the judgment is that Dr. Miners-Wallace apologised to the lady he was assessing. And this can be a really valuable tool to use, but you have to mean it. Because many of the questions that we ask people we're assessing can sound intrusive, they can sound impertinent, and they can sound patronising. And apologising for that, putting yourself in the person you're assessing shoes, can really help the assessment to move forward. The blank canvas approach, we need to avoid that. We need to avoid assessing people without giving them the information that they need to make the specific decision in question. The judgment I've referred to is where this arose, CC versus KK and STCC. And in it, His Honour Justice Simmons' colleague, his now Lordship Justice Baker, stated, and I quote, "The person under evaluation must be presented with detailed options so that their capacity to weigh up those options can be fairly assessed." It was explicitly said that capacity assessors should not start with a blank canvas approach. Practically speaking, what this means is that we, as assessors of capacity, must provide people with the information that they need to make the decision in question. And that might mean we need to do some research. For example, many of my assessments relate to people's decision-making ability and their capacity therein to decide where they wish to reside. And quite often, I don't know what the alternative is to them residing in their current placement. But to make a decision, generally one needs an alternative. And so I have to pick up the phone, have to speak to family, social services, to try and establish this information so that I can provide it to the person I'm assessing. It's really important. School teachers provide the children they're teaching with the information that they need. They don't expect the children just to know it. As capacity assessors, we have an obligation to do the same thing with the people that we're assessing. Over the course of the pandemic, we've all learned to undertake assessments in novel ways. And I've found that by and large, most of the people that I'm assessing can be assessed by video call. And it's been a real wonder to me at the delight, particularly in some of the older people who I've used this tool with, to see that they can speak with people in this remote manner. Seeing their delight when we've done so has caused me great joy. However, we must remember that there are a few people who cannot be assessed in this way. And there can be a variety of reasons for this. It may be that the person being assessed finds the abstract nature of a video call assessment too difficult to comprehend. And I found that with some people with learning difficulties or autistic spectrum disorder, but by no means the majority. Some cases, people simply want to be seen in person, and they say, "Don't want to talk to you in this way. I prefer to speak to you." And in those cases, we should be knocking on doors and seeing people to assess their decision-making ability, their capacity. I would caution against undertaking telephone call assessments. Why, I hear you ask? Why? Because so much is missed. Being able to see somebody when you're talking to them plays such an important part in the process of assessing somebody's capacity to make a particular decision. Non-verbal communication is crucial. The sign, the roll of the eyes, the look away, the smile, All of those things communicate something to us, and they are all missed if we are assessing somebody solely using the telephone. The law, specifically Part 1, Section 1 of the Mental Capacity Act, states that the following principles apply for the purposes of this Act. What it means is that we are legally obliged to follow the statutory principles enshrined in the Mental Capacity Act. They must be followed by us if we're assessing somebody's capacity to make a particular decision at all times. The first principle is crucial for you who are assessors to acknowledge, because it's your role to evidence if you have found that someone lacks capacity to make the specific decision in question. And you must establish a link between their mental disorder and their failure at a stage of the functional part of the assessment, which therefore means that they lack capacity to make the specific decision in question. You must evidence the blockage caused by mental disorder at the particular stage in the functional test, and you must document logically how you reached that conclusion. Statements such as, "This gentleman has Alzheimer's, so could not make the specific decision." Statements such as, "This person has a learning difficulty and so could not decide," are not assessments of capacity, because you have not established and evidenced a logical link. You must make specific reference to how the mental disorder displaces the presumption of capacity. A picture tells 1,000 words, so they say. And this is an issue that's come up time and time again over the course of my career when assessing people's capacity to make particular decisions. Hearing is one which I come across on a daily basis, and in fact did just the other day. I'll often find that the people I'm assessing have hearing impairment, but nothing has been done about this. And obviously, if you can't hear very well, it's very difficult for you to engage in a conversation or discussion. So I will often say, "Please could you have this person's hearing assessed?" And often it might be waxy ear, or they need a hearing aid, and then we'll return to undertake the assessment. But that's a simple, practicable step which can support people to make the particular decision being assessed. And it's a statutory principle of the Mental Capacity Act. There are numerous other examples of practicable steps that we can take to help support the people we're assessing to make the decision in question. For example, I've assessed people with brain injuries where there hasn't been a speech and language therapy assessment, or the last one was over a decade ago. Things have moved on, as we can see from the way that I'm communicating with you today. In other cases, people might have an underlying depression, or they may be psychotic, and those illnesses might not have been treated effectively. And treating them effectively can allow them to recover some of their decision-making ability, and we should be taking those practicable steps. Another key issue that we come across often are when people don't speak English as their first language. And in these cases, we should almost always be using translators. Even if the people are being assessed don't say anything, they don't speak, because I'll often hear that. Mrs. X doesn't communicate. But that doesn't mean we shouldn't be using translators, because if we don't use translators, then we're making an assumption and we're assuming essentially that they lack the ability to make the decision in question. Hence, our being there to assess their capacity is not required. And that's not part of what the law dictates we should be doing. We should be supporting these people. I remember a case that I did last year where their care home informed me that the lady I was assessing spoke an Eastern European language. I haven't named the language specifically for patient confidentiality reasons. Nevertheless, I arranged an interpreter and went to assess her, and it was only as this lady began to talk that the interpreter informed that she wasn't actually speaking the language, and we had to dig to find out what her first language was. It's so important that we do things and do things properly when we're taking practicable steps to support people being assessed. Take a look at that slide and remember it, particularly the picture of the man skiing down the hill in his nightwear. I'm not suggesting that this is a good idea, but that's the point. It's not a good idea, but people should be able to undertake things which aren't particularly sensible, which are unwise, if they have the capacity to be able to do so. The third principle of the Mental Capacity Act is really important, and I'm going to read it. A person is not to be treated as unable to make a decision merely because he makes an unwise decision. We as assessors have to remember that our role is to make an objective, impartial and detached assessment of their capacity. And that can be really hard to do. I find it hard to do as a doctor, because all of my training has taught me that it's my job to help people and help keep them safe and well. And sometimes when you're assessing people's capacity, they want to do things which are inherently risky and dangerous. Nevertheless, should they have the capacity to make that decision, then one should not be making a judgment that they lack capacity to do that. We should be avoiding what's called the protection imperative. And the case that I've referred to on the slide, the Oldham case, is one that was undertaken using the Children's Act 1989. And in that case, the judge referred to the protection imperative. He referred to it in the case of children and adults. And I'm going to quote, because I think it's really important for us to hear and to reflect on. Judge Ryder J. referred to a child protection imperative, which he described as meaning the need to protect a vulnerable child that, for perfectly understandable reasons, may lead to a lack of objectivity on the part of a treating clinician or other professional involved in caring for the child. He goes on to talk about cases involving vulnerable adults, saying, in cases of vulnerable adults, there is the same risk that all professionals involved with treating and helping that person, including, of course, a judge in the court of protection, he magnanimously said that, may feel drawn towards an outcome that is more protective of the adult and thus, in certain circumstances, fail to carry out an assessment of capacity that is detached and objective. I'll speak later about some of the problems that you may experience when you find somebody has capacity to make a risky decision. But we have to do our assessments properly in an objective, detached and impartial manner. I'm going to quote Baroness Hale, who in R versus C 2009 UKHL stated that such an outcome approach, which focuses on the final content of the person's decision, penalises individuality and demands conformity at the expense of personal autonomy. Baroness Hale was encouraging us to avoid employing the protection imperative. A sound assessment also requires assessors to understand the key elements of the functional test: understanding, retention, weighing up, and communicating. And understanding, retention, and weighing up are often poorly understood or muddled up. For example, a person who resides in a care home but doesn't believe they reside in a care home. These people are often documented as failing at the understanding stage because they don't understand that they live in a care home. However, the person being assessed understands the concept of a care home because they're saying, I don't live in a care home. They're probably saying, I don't need any care. It's not true. So they actually don't fail at the understanding stage, but the weighing up stage. Understanding is about understanding the concepts, the key concepts being assessed. It's not about being able to weigh them up. Retention is also something in terms of the functional test, which is often muddled with weighing up. And retention is very difficult to assess. However, most people over the course of my clinical experience tend to fail at the understanding or the weighing up stage, far fewer at the retention stage, because to fail at the retention stage, one must not be able to hold the key points of the information in mind. A great example, which was described to me last year, was the cup of tea test. You give somebody the choice of whether they want a cup of tea or coffee. They reply saying, I'd like a coffee. Then, a minute later, you ask them whether they like milk or sugar, and they're not able to answer. They've forgotten what you were talking about. They've not been able to retain the information you've discussed with them and hold it in their mind for a short period of time. That person would fail at the retention stage. However, if you speak to somebody, you tell them that they live in a care home again, and then at the end of the assessment, they tell you that they don't live in a care home, they haven't failed at the retention stage, because retention is holding information in mind and being able to respond to the questions asked about that information. You don't have to respond to it in a manner which agrees with it, but you have to respond in a manner which shows you've retained what's being discussed. And so retention is not remembering. And then we come on to weighing up. And when it comes to weighing up, we have to remember the protection imperative and not to employ our principles. Because if someone chooses not to place any weight at all on one of the key concepts, then they likely have capacity to make that decision because they're including the concept in their weighing up process. They are just choosing to put less weight on it than you or I might. And as such, they don't fail at the weighing up stage. So, we've spoken about how to undertake a sound assessment. We've spoken about rapport, researching and providing relevant information, the format of the assessment, following the statutory principles of the MCA, and understanding the key elements of the functional test properly. I haven't spoke about the methodology of undertaking the assessment because this varies so widely, but it will probably become apparent to you in the initial stages of the conversation you have with the person you're assessing. Sometimes it can be a conversational approach. Sometimes it might lead to you having to present the person you're assessing with information and asking them questions. We'll now move on to the importance of writing a dependable record of your assessment of capacity for the person you're assessing to make the particular decision in question. So, I referred to this earlier. The statutory principles of the MCA make it crucial that we have a mental disorder linked to the failure at the functional test. So we need to establish a causative nexus, as it's referred to, between the diagnostic test, that is the establishment of mental disorder, and the failure at the particular stage of the functional test. A statement of the mental disorder is insufficient because you must describe how, in what way does that mental disorder impair that person's ability to understand, retain, weigh up, or communicate the specific decision in question. Verbatim quotes are the gold standard. Writing down the answers that the person gave you, which evidences this. And also writing down the questions that you asked them verbatim, because then that shows your workings. And that's a phrase I really like to use. Show your workings. Write down how you reached the decision and the steps that you followed to do so. Don't just reach a decision without doing that. It's really important because the burden of proof lies on us as assessors of capacity to establish that the person lacks capacity. The person themselves has nothing to prove at all. General statements are rarely helpful and we should avoid using these. The case I mentioned is really important, and again, I'm going to quote from the case, where the judge, Hayden J., criticised the assessor for not recording the decision they had been asked to assess, stating that this could be fatal or at least gravely undermines the assessment. What this means is that it's really important to explain to the person, as I discussed earlier, why you're there and what decision you've been asked to assess their capacity to make, and to do this in a way that they understand, but also to record that you did so. So, I've covered how to undertake a sound assessment. We've spoken a little about how to prepare a report that stands up to scrutiny. And we'll now move on to some of the difficulties you might experience in your clinical practice. I acknowledge that some of these difficulties might not apply to all of you, but hopefully there's something of interest here for you, because many of the people that you as professionals deal with will have been throughout a variety of clinical settings over the course of their lifetimes. The first obstacle I'm going to discuss is the Mental Health Act and Mental Capacity Act conundrum. And this only applies in clinical settings where the Mental Health Act can be utilised. What that means is it can generally only be applied in general hospitals, teaching hospitals, and psychiatric inpatient units. Units that are registered to hold patients who are detained under the Mental Health Act. I'm going to spend a lot of this slide looking down, not because the subject matter itself makes me feel downhearted, but because I'm going to have to do a lot of quoting from legislation, because I think it's really important for us to understand this, because it often comes up as an issue. So let's start with the Mental Capacity Act, Schedule 1A, the Mental Health Act, the legislation itself, and the Mental Health Act Code of Practice. We're bound to follow both the Mental Capacity Act and the Mental Health Act because they're the legislation, they're the law. We don't have the choice not to follow them. We're also bound to follow the codes of practice, which is statutory guidance. They're not just guidance, there's the statutory word there. We're obliged to follow those, and we can only deviate from them with good reasons. And you've got to be able to evidence your good reasons from deviating from the code of practice, as you'll know. So, what is objection in a clinical setting? Objection, as it refers to ineligibility for DOLS, which is where the Mental Health Act and Mental Capacity Act conundrum arises, is referred to in Schedule 1A of the Mental Capacity Act 2005. KC in particular, and I quote, "Within the scope of the Mental Health Act, but not subject to any of the mental health regimes." What that statement means is that if the person being assessed is within the scope of the Mental Health Act, but not detained under the Mental Health Act, then if the person being assessed objects to being an inpatient in the hospital or to any of their treatment for mental disorder, then they are ineligible to be deprived of their liberty in that hospital under DOLS. So, we first have to establish in law why the person being assessed is ineligible to be deprived of their liberty under the deprivation of liberty safeguards, so using the Mental Capacity Act legislation. And in relation to ineligibility, we're obliged to follow the law, which I've mentioned, Schedule 1A of the Mental Capacity Act. And I've spoken about KC, which relates to objection. We then have to give some thought to the concept of objection. What does that mean? And here we have to pay regard to the Mental Capacity Act Code of Practice. And that's the statutory guidance I've referred to. And paragraphs 4.45 to 4.48 are relevant in relation to objection. Of particular relevance is paragraph 4.47, which states that assessors should always bear in mind that their job is simply to establish whether the person objects to treatment or to being in hospital. Whether that objection is reasonable or not is not the issue. So, if the person that you're assessing objects to being in hospital and says that they can go home safely, despite the fact that they've been leaving their oven on all night and their door open, doesn't matter because they still object to being in hospital. The reasonableness of their objection is not the issue. We then also have to look at the Mental Health Act Code of Practice. And we have to give some thought to paragraph 13.51, and that's relevant to objection. Because what it says is, and I quote again, "In many cases, the patient will be perfectly able to state their objection. In deciding whether a patient objects to being admitted to hospital or to some or all of the treatment they will receive there for mental disorder, decision makers should err on the side of caution and, where in doubt, take the position that a patient is objecting." What that means is that where there is that doubt, we as assessors should take the view that the person is objecting, not that they are not objecting. We then, of course, have to consider case law. And again, I'm going to read. In GJ versus the Foundation Trust 2009, the judgment makes it clear that we as assessors do not have the liberty of choosing between DOLS and the Mental Health Act when, for example, the person does not meet the eligibility criteria to be deprived of their liberty in hospital under DOLS. The judgment itself states that it is not lawful, and I'm going to repeat that, it is not lawful, which the judge said, for the medical practitioners referred to in the Mental Health Act, decision makers under the Mental Capacity Act, treating doctors, social workers, or anyone else to proceed on the basis that they can pick and choose between the two statutory regimes as they think fit, having regard to general considerations that they consider render one regime preferable to the other. What that means is that if somebody is ineligible for DOLS, then it cannot be used, and we can't choose to use DOLS over the Mental Health Act, and vice versa. So we then have to look at KC in a bit more detail under Schedule 1A of the Mental Capacity Act 2005, where it states that the person being assessed must fall within the scope of the Mental Health Act, but not be subject to any of the mental health regimes at present. To fall within the scope of the Mental Health Act, then the person being assessed must have a mental disorder as defined in the Mental Health Act. And I won't go through the definition of mental disorder because it's easy enough to find in the Code of Practice and in the law itself. What I will, however, state is that in relation to DOLS, Schedule A1, paragraph 14.1 of the Mental Capacity Act, the law itself states that the relevant person meets the mental health requirement, and the Mental Health Act requirements here refers to, the mental health requirements here refers to the mental health requirement for a person to lack capacity to make a specific decision if he is suffering from mental disorder within the meaning of the Mental Health Act, but disregarding any exclusions for persons with learning disability. What that means is that if someone doesn't have a mental disorder, then they cannot be deprived of their liberty under DOLS, nor can they be deprived of their liberty under the Mental Health Act. I'm yet to come across a case where the argument that the person that's being assessed who is ineligible to be deprived of their liberty under DOLS does not have a mental disorder as defined. We then have to think about what is medical treatment for mental disorder. And luckily, the legislation itself describes this. And again, I'm going to read and quote. In the Mental Health Act legislation, it states, medical treatment includes nursing, psychological intervention, and specialist mental health habilitation, rehabilitation, and care. What this means is that care which is provided for patients who have, for example, dementia, that could be care such as washing and dressing, supporting them to feed, is medical treatment for mental disorder. And should they be found to object to this, and they are kept in a setting where they're deprived of their liberty, and which is registered to hold patients who are detained under the Mental Health Act, then they may well be ineligible for DOLS. The Mental Capacity Act provides no framework to protect other people. It cannot be used for this, whether it be in the inpatient settings, which are registered to hold people who can be deprived of their liberty under the Mental Health Act, or whether it be in the community. The Mental Capacity Act cannot be used to protect other people. In the former settings, we should be thinking about using the Mental Health Act because this can be used to protect other people. And in the community, we should be thinking about asking a judge to make a decision. But it's not the role of the Mental Capacity Act to protect other people. Finally, there is no provision at this point in time, until case law arises, for people who are in hospital, who are objecting to being there, and are simply awaiting placement from being exempt from the provisions of the Mental Health Act. And as such, they can be detained under the Mental Health Act, should that be the appropriate legislation to use under the law. Next, we'll look at what to do when people tell you to go away. Now, I'm not talking about the people you love telling you to go away. I'm talking about the people that you're assessing. because it's going to happen. Sometimes people simply don't want to be assessed. Sometimes there might be a very good reason for that. But the fact that an ability, a decision-making ability, cannot be assessed does not mean that it's not present. And as such, a refusal to be assessed does not mean that the person who we're trying to assess lacks capacity to make the specific decision in question. First of all, we have to think about why might they be refusing to be assessed. It might be the time of day. It might be the approach. It might be the nature of their mental disorder. But the Mental Capacity Act provides us with no tools to impinge upon people's civil liberties to allow them to be assessed. So what do we do in these cases where we've tried, and we've tried again, and we've tried again, and we keep getting told to go away? We should approach the Court of Protection, and we should ask them to make an interim judgment. In these cases, we don't have to evidence why someone lacks capacity. We have to evidence why we think someone may lack capacity. And again, I'm going to quote, we have to justify a reasonable belief that the individual may lack capacity in the relevant regard. This means that it's possible for us to refer the person we're trying to assess and who's refusing to be assessed to the Court of Protection to allow them to make an interim order. And the legal process, the judicial process, will then allow the wheels to be put in motion so that the person that we have not been able to assess can be assessed. But we should not be jumping to conclusions and equating a refusal to be assessed to a lack of capacity to make the specific decision in question. Much of the time that will be the case, but certainly not all the time. And because of the presumption of capacity, someone must be assessed before they can be deemed to lack the capacity to make a specific decision. And it's the role of the judge to make a decision in the interim. Regarding the protection imperative, should someone be assessed to have capacity to make a specific decision which exposes them to significant risk, then that does not discharge us from our professional obligations to try to safeguard them. Going to my previous point, which I made earlier in the presentation, the first thing we need to do is undertake a good quality assessment of capacity. A line in the note saying that the person has capacity to make the specific decision which exposes them to risk isn't sufficient. It's not good enough. Regardless of the presumption of capacity, if you're commenting upon capacity, you should evidence how that conclusion has been reached. If the patient is at risk, if they're vulnerable and they do have capacity to make the specific decision in question, then we have a professional responsibility to think about how we can safeguard them. That could be a clinical discussion with the multidisciplinary team. That could be offering care. And in those cases of most significant risk, that could be employing the apparatus of the Mental Health Act in the appropriate settings, or it could be seeking intervention from a judge. The presumption of capacity is used with particular prevalence in my experience to avoid intervention in the cases of people who present in emergency departments having self-harmed or taken overdoses, and also in cases of neglect. I've mentioned the House of Lords Select Committee's post-legislative scrutiny upon the Mental Capacity Act 2005, and I'm going to quote from their comments, which refer to this. The House of Lords Select Committee said, "The presumption of capacity, in particular, is widely misunderstood by those involved in care. It is sometimes used to support non-intervention or poor care, leaving vulnerable adults exposed to risk of harm. In some cases, this is because professionals struggle to understand how to apply the principle in practice. In other cases, the evidence suggests the principle has been deliberately misappropriated to avoid taking responsibility for a vulnerable adult." In layman's terms, what that means is we should not be using the presumption of capacity as a rationale for not intervening. I'd now like to move on to talking about lessons learned amidst the pandemic. Firstly, remote assessments, assessing people in this manner, Zoom, Microsoft Teams, my heart sinks when I hear that, WhatsApp and FaceTime. And a particular mention must go, and I'm going to have to look at my computer screen now, to LifeSize. Would you believe that that is a video conferencing tool used in one hospital in the UK? It's a tool I've never heard of, nor of most people. And I think it's incumbent upon us to think, what are the tools we can use to best help the people that we're trying to help support? Video conferencing is the future, both in terms of engaging with people, whether it be the people that we're assessing, our patients if we're clinicians, and other professionals, and we would do well to embrace it. As I discussed, it works the majority of the time, not all the time, but the majority of the time. And it allows us as professionals to use our time efficiently, whilst also allowing the vulnerable people we assess potentially much wider access to the world outside the setting in which they're placed. The importance of undertaking an individualised assessment is, however, so crucial, and it bears repeating. We shouldn't be using video calls as the go-to for everybody if they're not appropriate, because there's a minority of people whom they're not appropriate for, and in those cases we should be doing what's best for the person being assessed. Elements of being a capacity assessor can be challenging, to say the least. And I think that the pandemic's really reinforced what I already knew, that we have to be persistent and resilient. And I feel very lucky to be here today speaking to you, because I'm sure you've all come across some of these difficulties and you've had to show integrity and work with persistence and resilience to try and support the people you're assessing and to do the best by the people that you work with clinically or in your social work positions or your care positions. Some examples of the things I've experienced over the course of the pandemic are being asked to call at a good time for the professional body involved, but not for the person. Call after lunch, even if the person is best at lunch, they're most awake then. And in those cases, we have to say no. We have to remind the people we're talking to that we have to do the best for the people that we're assessing. Something else that I've heard over the course of the pandemic, and this was endemic at the beginning of the pandemic, I like what I did there, when I was constantly being asked just to phone, everybody else phones, just phone, and not to employ video calls. But as I discussed earlier, so much is missed. And actually, I've not had to assess anybody using a telephone, because with perseverance, eventually I've been able to manage to undertake a video call, albeit it's not been easy at times, but it's getting easier, thankfully. Something that's really important for us as capacity assessors to remember is the importance of our role. And I think we would do well to remind ourselves of that from time to time. Our role is crucial because it fundamentally comes down to us assessing aspects of other people's lives that we would not want removed from ours. What am I talking about? I'm talking about our autonomy to make decisions. I'm going to read again now. A gilded cage is still a cage. Lady Hale. It is axiomatic that people with disabilities, both mental and physical, have the same human rights as the rest of the human race. It's important, it's crucial that we do our best to support people we're assessing to make the decisions we're assessing their capacity to make. We shouldn't be jumping to conclusions. We should be allowing them the same human rights as everybody else. The gentleman in the picture is Paul Laurence Dunbar. He's one of the first African Americans to develop a national reputation for his poetry. He died in 1906 at the age of 33. And his poetry sits in the Library of Congress. And I'm going to read. I know why the caged bird beats his wing, till its blood is red on the cruel bars, for he must fly back to his perch and cling. I really wanted to put a picture of Spider-Man in here, and particularly this Spider-Man movie. If you haven't seen it, you should. Google the picture. Anyway, I'm not here for my movie reviews, but to talk about assessing capacity. Superheroes. We should remember that we get to speak to real life superheroes every day. Over the course of the pandemic, I've been reminded of the incredible bravery and fortitude of the people that I assess. Some of them are aware of the pandemic, some of them aren't, yet they feel the impact upon their lives of it. And much of the time, they've presented to me with directness, humour and brightness. I've learned much from them. I've had several favourites this year and last year. The lady who liked to travel on a bus to a service station in the middle of the night, much to the consternation of professionals because of her delusional beliefs, despite having the capacity to do so. Every day, I work with people in restricted settings with cognitive impairment, brain injuries, or learning difficulties, who remind me of the true meaning of the word bravery. We owe it to those people to do our jobs properly. And I guess that's why you're all here today. Our role is to support these people to live a full, happy life, despite the challenges and risks which are often associated with doing so. So, those of you who enjoy a Hawaiian pizza know that the freedom to make an unwise decision, mixing pineapple with pizza, for example, is to be cherished. Finally, to the theme of today's conference. I'd like to speak to you a little bit about some of the cases that I've been fortunate enough to be involved in as part of the team who've been able to hopefully improve people's lives, their liberty and their happiness. I'd like to start with the gentleman I assessed in a care home last year. He was an older gentleman who unfortunately was dying, and he was originally from a country in Africa. I haven't named the country for patient confidentiality purposes. He wanted to return to his village in Africa to die. I found that he had capacity to make that specific decision, and I hope now that he's been able to go back home to live out the rest of his days in his village. I'd also like to talk about the gentleman who wanted to watch cricket live in person, hence the picture of Sir Gary Sobers, possibly the greatest all-rounder the world has ever known, from the island of Barbados. The gentleman I assessed didn't have capacity to make the specific decision I'd been asked to assess. However, he did say to me that he was pretty fed up, didn't like watching cricket on TV, and wanted to be able to get outside in summer prior to the pandemic to watch a cricket match. I was able to put his suggestion forward, and I very much hope it's been taken up upon, and that prior to the pandemic he was able to sit out and watch a cricket match live. I'd like to finish with talking to you about the Colonel. This was an older man I assessed a couple of weeks ago in a care home. He'd been a colonel in the armed forces, a position of respect which he'd earned and worked for over the course of his lifetime. He was referred to by his first name by the staff in the care home because they weren't aware that he'd been a colonel. I spoke with his family, and when I referred to him as Colonel, the look on his face was incredible. He was so happy. He'd been referred to by his title, his position of respect. Little things like that can be life-changing for people, and we all here today, as part of the teams we work in, have the ability to do this. Thank you.
Ben, thank you so much for that. I know that everybody enjoyed that, and you've sparked such a debate about pineapples and pizza.
There's no debate to be had there, too. There's no debate to be had there.
So Ben's been looking at your questions and answers, all the questions as we've gone through, and he's answered some of them. I'm going to try and pick on some questions, but while I try and find something that might be useful, is there anything particular that you wanted to talk about, Ben?
There's a lot of questions, and I think they raised themes which come up and have come up for us a lot as professionals who are assessing capacity. It was one asked by somebody anonymously, it was more a comment on the practicality and the availability of tech to undertake assessments. And I think that it's definitely something I've struggled with, and I've said as much. And what that means is that you have to be resilient, and you have to be asking care homes and hospitals to employ it. And I remember taking 3 days last year at the beginning of the pandemic, trying to get a particular hospital to let me assess a lady with dementia via video call, because they were insistent that I just did it on the phone. And I just refused to believe that a hospital does not have the availability, or there is someone who does not have a mobile phone that will not allow me to see this person, and vice versa. So there are those issues, but I think that they will change as time goes by. I think the other thing, and Josh Simmons mentioned it earlier, is there are definitely some people that you can't assess by video call, and we shouldn't be using it as the default. We shouldn't be saying, this is what I've been told to do, and we should do it for everybody, because the decisions we make are huge. And I think one of the most telling things for me, as somebody who's involved in assessing capacity in lots of different spheres, is to put myself in that person's shoes. What would I want? Would I want to have someone chatting to me on the phone and then coming to a conclusion which could have a massive impact on my life? Probably not, I don't think. I'd want that person to be seeing me. And in terms of video calls, what I've found is that the people that can't use that technology, you're often able to tell fairly easily by employing it. So those were 2 points that people raised over the course of the assessment that were Hawaiian pizza unrelated. So I thought I'd raise those. There were a couple of other questions that people mentioned, particularly in terms of hospital admissions. It's really difficult, and it's a really contentious area, but it shouldn't be, because as the case law shows, and I referenced the case law in the questions for people that missed it, if somebody is objecting and they're ineligible for doles, you can't then use doles. And in fact, there was a QC who has commented on this. I can't remember who it was, who said basically, if there's a disagreement among professionals, then it should go to a judicial review. There was a mention about delirium and dementia as well, particularly delirium. Delirium under the legislation is a mental disorder, and I'm going to quote now. So it is Part 1, F1 of the Mental Health Act. A mental disorder is any disorder or disability of the mind. There's no exclusion for delirium or an acute confusional state. And actually, if you go into the Mental Capacity Act Code of Practice, then, and I quote now, paragraph 2.5 states, organic mental disorders such as dementia and delirium, however caused, are written there as examples of mental disorder. And so it's really important to remember that delirium is a mental disorder. So I hope that's helpful. I'm just seeing a lot more questions have come up actually. So I'm just going to.
It's one that I thought would be quite helpful for you to answer, Ben, and it ties into some case law that that's fairly recent about. Would you always tell a person they're having a capacity assessment, or is it sufficient to say that there are worries about them?
No, it's not. And I think you have to look at the Hillingdon judgment, the recent Hillingdon judgment in relation to that, because the judge in that case criticises the capacity assessor for not documenting that they'd discussed that. But the presumption from that is that it hadn't been discussed. And again, I think you have to put yourself in that person's position and think, if somebody was going to make a decision about my life and my place of residence and the care that I receive, for example, I'd want them to talk to me about that and tell me that that was their job. They might not be able to comprehend and weigh it up, but at least show these people the respect that you should in doing that. And I know sometimes it can be really difficult, but you don't have to do it in a rigid way. You should do it in a way that they understand. So I often say, I am just thinking of a good example. So I often say when I assess younger people that I'm here to have a chat, and I'm here to have a chat about where you're living. But my job is to see whether I think you can decide where you want to live, or if you want to live somewhere else. And I give them the specific example of the way they want to live. And that comes from having the information. You need the information to give them, because they need to be able to make a choice, and to make a choice you need things to choose from. One point somebody mentioned in the question and answers was, and how can someone who doesn't believe they're in a care home understand? And that's a common misconception, that you see somebody in a care home facility, they don't believe they're in a care home, they don't believe they have dementia, they don't believe that they have anything wrong with them, they believe that they're getting on with their life, they've got a job. What is key in terms of understanding, it's not understanding that they're in a care home, it's understanding the concept of a care home. So if you talk to somebody and say, no, I don't live in a care home, I don't need any help, then clearly they understand the concept. They understand the concept of a care home as being somewhere where people who are older, infirm, have difficulties which they need care and support for reside. And so they do understand. Where they fail is weighing up, because they're not able to place weight upon the fact that they live in a care home and that they have a mental disorder, as it would be, or a physical health problem, which means that they have to reside there. And I think that that's really important, because understanding and weighing up, as I said in my presentation, are something that's really, really commonly confused. So I thought that was an interesting one. I'm just looking through the, yes, I've just answered that question, clarify regarding the issue of understanding weighing up. Hopefully that helped. Where it says, somebody said, hi Ben, would you class learning difficulty but not an LD diagnosis, a mental impairment of the act? Interesting question. First of all, you don't have to have a formal diagnosis to have a mental disorder for the meaning of the Mental Capacity Act and indeed the Mental Health Act. There is nothing in the law which said you must have a diagnosis. And people get very hung up on diagnoses, and actually they're not relevant in terms of the legislation. What is relevant is, do people have an impairment of the mind or brain, as is documented in the law? With regard to learning difficulties, there are specific exclusions under the Mental Health Act and the Mental Capacity Act. Under the Mental Health Act, you can only consider learning difficulties to be a mental disorder if people are acting, I can't remember the phraseology, I think it's irresponsibly and posing significant risk. There is that exclusion though under the Mental Capacity Act. So learning difficulties under the Mental Capacity Act are considered to be a mental disorder. And again, that's in the legislation itself. So if you have a look in the legislation, it's pretty clearly scripted there, so it's easy to see. Somebody has said doing a video assessment is also important for picking up how relaxed the person is in the home and how they're relating to the staff there. That's a very good point. Luckily for me, I tend to ask them to walk. I tend to ask the staff in the home actually to walk down the corridor with the phone or the mobile device so I can have a look around. I absolutely agree. It's not as good as assessing somebody on a mobile device at picking up the environment of the home, seeing whether people are being cared for properly, if people are falling over, whether it's clean. So there are definitely things that are missed via video call, but my conversation was about assessing capacity, and I think in most cases it can be done remotely, and I think as time goes by, I think it will probably be done so more and more. Sue, did you have any other questions you want to raise with me?
I'll just wait till I just wanted to hop in. One of the questions which I think is quite interesting is when the Act says that we must both assume capacity, does that conflict with the whole point of the assessment, and how can we both assume capacity and at the same time perform an assessment to test it?
Well, so our role is to undertake an objective, dispassionate assessment of capacity. The purpose of the Mental Capacity Act is for those cases where there are concerns that someone may lack capacity. So you have somebody, for example, who is living at home, they're living in abject neglect. There's concern that they may not have capacity to make the decision to live independently because they're refusing care, let's say. And so that question is, of course, raised. Now, that's not, but you as an assessor do not go in with an assumption that they lack capacity because they're not caring for themselves. There is the presumption of capacity, and you must evidence if they lack capacity. So I don't think that it's conflict, because there are always cases where people are viewed to be making decisions which are dangerous or unwise, and because there's worry about mental disorder, then the issue around capacity is raised, and the key is to be dispassionate. when you're making that assessment and to undertake it objectively. But I don't think that the two don't conflict in my mind.
So, Ben, I was going to ask you a question that's not in the question and answer session, really.
Sure.
Only because you've talked to us about LPS, and that I don't know if I got it right that you advised the House of Lords on LPS. Just wondered if there was any insider knowledge that you could give us.
So, in short, no. I was asked to advise the Lords on some of the terminology, particularly around mental disorder in the LPS, and from my experience of undertaking mental capacity assessments. But no, I don't know what's happening. I don't know in terms of delays or anything like that. So in answer to your question, Sue, rather unhelpfully, I have to say no, I don't, I'm afraid. I'm just reading the last, somebody's commented, so specifically, if I assume someone has capacity, doesn't this mean that I should therefore treat them as if they do? If that is the case, it seems to exclude me doing a mental capacity assessment, I'm guessing. No. Yes, you must presume that someone has capacity, and yes, you must treat them as if they have capacity, but that doesn't exclude you from undertaking an assessment to establish whether or not, in your view, on balance of probability, they lack capacity. You are there to undertake an objective, detached assessment of their capacity. And the fact that there is that presumption of capacity does not mean that capacity might not be displaced by mental disorder. So no, it doesn't exclude you from doing an assessment, because otherwise we wouldn't assess anybody, and we'd say everybody had capacity to make every single decision they ever made, which is clearly not the case.
Can I jump in again?
Yeah.
Sorry, I was on mute. So I was just picking up on another question, actually, Ben, and it's certainly one that we've experienced here. So there was a recent court protection case where the judge did focus on the lack of diagnosis, and I know certainly we've had that here, where we've had somebody who's got a diagnosis of probable dementia, but because of the way services are set up in the county, the person couldn't actually get the diagnosis in the setting they were in, and we did have a little bit of a hang up with court over that, because they were saying, but we need a diagnosis, and we had to kind of, there does seem that the mental capacity act in practice, and then there's the mental capacity act in court, and sometimes they don't always marry.
No, absolutely. And I think that the case you mentioned is really important, because that's judge dependent. And I think it very much depends on both the judge that's sitting, but it also depends on the merits of the case itself.
Can they hear me?
And are you able to hear me, Sue? Okay. So it very much depends on the judge who's sitting and the merits of the case itself. And because a judge asks for a diagnosis, and as Judge Simmons said right at the beginning in his presentation, judges are able to ask for whatever evidence they want. And I think that in cases where it's equivocal, then I don't think it's an unreasonable thing to request, but it's not necessary. So I think that hanging everything on the hat of diagnosis is not required. And I think as long as you can, you need to be able to evidence what that mental disorder is, how it shows. This person has cognitive impairment, is a phrase I often use when people don't have formal diagnosis, but it's apparent that they have an amnestic impairment, they have an impaired memory, for example. Someone's asked, are you distinguishing between learning difficulty and learning disability? Again, a really good question. I actually don't use the phrase learning disability, much to some people's annoyance, I think, because in my view, it's very old-fashioned terminology. And as Heidi's mom, I think it was, wasn't it? She said, Heidi's Heidi, she's not a disability. So I use learning difficulties for anybody I see who has learning difficulties, as I phrase it. I think people in the past always used to be termed as having learning disabilities. And that's not to say that people with learning difficulties don't have disabilities. For me, I don't think it's a very empathic terminology to use for people. And so I use the phrase learning difficulties to describe the people that I assess, because I think it's more respectful.
Thank you. Can I hop in for sort of wrap
up? Of course.
So we're kind of coming to the end of the question and answer session, Ben, and I thought I'd be really cheeky because it's kind of getting to that time of the day. I've been up since 5:30, and I think everybody would like to know, what is your bestest unwise decision that you've ever made?
My bestest unwise decision. Oh crikey, that's a great question. I think that was probably hitchhiking from Birmingham to London with a truck driver when I was 19 years old at medical school, with nowhere to stay. I think that was a great example of an unwise decision. Yeah, I hope to continue to make many unwise decisions in my life as I go by, as I'm sure we all do.
So that's Ben, thanks ever so much. I know that you've gone down a storm. I can see from the chat bar that people are really animated, and we've really enjoyed working with you. So we knew that you'd go down well this afternoon. So thank you so much for your time. Really appreciate it.
It's a real pleasure. And just to finish on the note I mentioned during my presentation is that everybody who's attending today and all of you who work in the field of assessing capacity should value yourself and your worth and how much importance your job has, because I think it's often not recognised outside of our fields, but it's crucial. And again, put yourself in that person's position and think how important it is. So no, it's been lovely to be here. Thank you so much, everybody. Enjoy the rest of the conference.
Thank you, Ben. So we've got a short break again now. And so please do just grab some fresh air. Please don't duck out and miss the last session, because it's Lorraine Curry. She's absolutely awesome, and I know you're really going to enjoy Lorraine for the last session. So the link for the next session will be posted in the chat bar, although many of you will already have it. So if you could be back at 3 o'clock, we will carry on with our final session. Please come back. And thanks once again to Ben and to Sandy and to the lovely James and Heidi. And again, I can see James and Heidi have absolutely gone down a storm with you all, so we'll see you soon.